Hello and welcome. I think we are in the middle of recording. Disregard the sound in the background. Andy is up playing with his mom. But I wanted to get these notes recorded and out to you guys as quickly as possible. So today we're going to be lecturing on Module 73, which is all about the biomedical therapies. This module begins on page 740 in your textbook. If we begin our first big question, what are the drug therapies? How do double-blind studies help researchers evaluate a drug's effectiveness? First and foremost, let's talk about what biomedical therapies are. Every treatment that we've discussed so far has been a form of psychotherapy in which through working with a psychologist, working with a therapist or a counselor, trying to get you to have a new perspective, a new point of view, maybe to give you hope. Those are all fundamentally different than the biomedical therapies. When we talk about psychology, we talk about the biopsychosocial. This treatment affects the bio aspect of it. The key is to change the brain's chemistry in an attempt to try to improve whatever disorder that you have. One technique is, did he poop? Nice. One approach is drug therapy. The term that we might use is psychopharmacology. Psychopharmacology is the study of the effects of drugs on the mind and behavior. Essentially, this is better living through Prozac. This is, helping you with Zoloft. This is giving you a pill that is designed to change the neurotransmitters in your brain so that whatever chemical imbalance might be going on, this is resolving that. Within that field of psychopharmacology, we need to talk about this idea of the placebo effect. This is a concept that you've heard of before. The placebo effect is just simply, I believe something's going to work, so it works. If I have a headache, I might take an Advil, I might take a Tylenol, and within 30 seconds to a minute, all of a sudden my headache goes away. Now, from a chemistry standpoint, there's no reason that it's going to be that fast acting, and yet, because my brain's like, oh, well, I should start feeling better, my brain starts to feel better. Because the placebo effect exists, when we conduct any sort of experimentation on a pill, we need to do a double-blind procedure. We need to make sure that the subject doesn't realize if they are receiving the actual medication or a sugar pill, a water pill, something that has no chemical properties. So if I were trying to quit smoking, or if I was trying to run a study in which people were trying to quit smoking, I would have my actual nicotine pill that is supposed to be tested as to whether or not it's effective versus a just generic whatever water pill, sugar pill. The funny thing is that with both pills, even in the nicotine pill that let's say doesn't work at all, in both groups, the group that gets the control, the group that gets the experimental treatment, both will see a decrease in nicotine cravings simply because they're like, oh, well, I'm taking a pill that's going to reduce it. So with this, we want to make sure the subject doesn't know whether or not they're getting the real pill or the placebo, the fake pill. And so we need to hide that truth from them. That's called the blind procedure. It becomes a double-blind procedure when both the subject and then the experimenter, whoever the person is that's actually running the experiment, they don't know who's getting the real pill versus the placebo. All they know is this is group A and this is group B, and they don't know if A is the control or B is the control. So oftentimes there has to be somebody managing the study that never interacts with any of the subjects to determine whether or not, like, which group is the control, which group is the experimental. Now, when we actually talk about the pills themselves, the three big categories that we're going to talk about are going to be antipsychotics, anti-anxieties, and antidepressants. Antipsychotic medications are going to be used predominantly to treat people who are not in touch with reality. Remember, a psychosis is a psychological disorder in which a person loses touch with reality. The most common psychosis that we've talked about, the one that's most prevalent, is schizophrenia. So something like thorazine, which is also called, and I'm going to butcher this, chlorpromazine, are both supposed to dampen responsiveness to stimuli that are irrelevant. Remember, with schizophrenia, one theory is You and I hear the same things that a schizophrenic hears, but we filter out things. I have the hum from the computer fan right now, but my brain does not pick up on that sound the way it does on a baby's voice. So these basically block dopamine. They're antagonists. There is a pretty significant side effect to this. It's called tardive dyskinesia. This causes people to have facial tics while on the medication, or different muscle spasms in the mouth or tongue. There are some videos on it. I don't know if it's in this PowerPoint or not, but you can pull it up on YouTube, or maybe I'll share some of those to you guys. Other side effects include things like obesity and diabetes. Our next group of drugs is the anti-anxiety drugs. These are going to be things like Xanax or Ativan. These are going to depress nervous system activity. There is a significant risk of addiction with these particular medications. These are usually paired with psychotherapy. Instead of just, here's the pill, good luck, oftentimes because of the addiction risk, and because these medications don't treat the root cause of the anxiety the way that psychotherapy does, that would be a reason why we'd want to pair it with actual psychotherapy. Our third group of medications are going to be our antidepressants. Because depression is so dependent on the neurotransmitters in the brain, these are going to work with Prozac, Zoloft, Paxil. Those are common names of the antidepressants. These are going to be serotonin and neuroepinephrine agonists. The goal is to try to increase the supply of neurotransmitters to boost your mood. I've talked a little bit about SSRIs, selective serotonin reuptake inhibitors. So the axon is sending these happy, feel-good chemicals into the synaptic gap. Some of those neurotransmitters are landing on the next dendrite. Typically, there's more that floods into the synaptic gap than there are receptor sites on the next dendrite. So a lot of those little molecules, a lot of those little neurotransmitters are left in that synaptic gap and will actually return to the sending axon, a process known as reuptake. Well, here's the problem. Those landing sites on the receiving dendrite will open up, but there is no serotonin in the synaptic gap to actually fill that until the previous axon gets signaled. There's a delay in terms of how long it will then take that previous axon to release that serotonin that was just out, that was just available. And so what an SSRI does is the sending neuron pushes out the serotonin. The receiving dendrite says, oh, this is great, bring that serotonin. Now, normally the reuptake sends the serotonin back, but now this blocks that reuptake, meaning that serotonin, those serotonin molecules are stuck in the synaptic gap, but that's okay. That's actually a really good thing, because when the landing sites, when the receptor sites on the actual receiving dendrite then clear, they don't have to wait for the sending axon, the sending neuron to actually send that information, send that neurotransmitter, send that serotonin into the gap, because guess what? It's already there through selective serotonin reuptake inhibition. Some of the side effects with those are going to be dry mouth, weight gain, hypertension, and dizziness. With antidepressants, we also see things like neurogenesis, the growth of new brain cells has been effective. Also with antidepressants, we realize that the placebo effect accounts for up to 75% of a drug's effectiveness. So we also note that antidepressants are not as effective in cases of people with mild or moderate depression. Those medications are going to be more beneficial with people with more severe cases of it. Significant placebo effect. Cool. Okay. So we've talked about antipsychotics, anti-anxieties, antidepressants. We're also going to talk about our mood stabilizers. These are pretty straightforward. We're going to see our mood stabilizers are going to be used for people with bipolar predominantly. Lithium and depakote, yes, used for lithium. We've seen that lithium has shown to reduce patients' risk of suicide. We see that with this treatment, we don't really understand why it works. It's basically just a simple salt that came about in the 1940s, but for some reason it does work, and so it's oftentimes used. Depakote is an interesting one because originally it was used to treat epilepsy, but it's been shown to have an effect on the manic state of bipolar. Our next topic is brain stimulation. So we've talked everything about chemistry so far, but remember the brain is both electro and chemical. When a neuron fires, it is electricity that is passing through. So is it possible to actually send electricity to different parts of the brain to change how they electrically and chemically behave? Well, one technique is called ECT, in which an electric current is sent through the brain of a severely depressed individual. This is not like the olden days of like electroshock therapy, which was used. Now, what we do is we put somebody under a general anesthetic and a muscle relaxant. Oftentimes, people will experience they will forget the actual treatment itself. However, there doesn't seem to be long-term brain damage. This is kind of not a last resort, but definitely it will come after we've tried our antidepressants, after we've tried our Zoloft. It seems as though this is an effective treatment for severe depression. Likewise, we don't really know why it works. There may be a placebo effect to it. It's certainly raised some eyebrows in terms of ethics of it, since we don't know some of the long-term effects of it. We do see with people with severe depression, 4 in 10 who've received ECT end up relapsing into a depressive state later on. So it's not a cure-all. But realize these are severe cases. So like, in all honesty, 4 out of 10 actually who relapse, meaning it's effective 6 out of 10, 60% of the time. Like, these are people who are drug resistant. These are people who've tried lots of different things. They've tried psychotherapy. They've tried pharmacology. They are now trying this. Like, this is depression that is really, really in the brain, like deep in the brain. So to say like, oh, well, 4 in 10, I don't like the way that they frame that. I feel like 60% success rate is actually pretty good. Our other type of brain stimulation is called RTMS, in repetitive transcranial magnetic stimulation. In this case, the person is awake during the entire process, and we just basically shoot small electric magnetic currents through the brain on people who are awake. There are no seizures, no memory loss, no serious side effects, although headaches can result. There are modest positive benefits, although again, we don't really know why it works. Perhaps this is something that causes stimulation of new brain cells to develop. Maybe this is something that leads to new functioning in the brain learning new ways to respond to different stimuli. Our next kind of brain stimulation is our deep brain stimulation, in which we actually perform a brain surgery and we implant electrodes in negative emotion centers of the brain that are designed to inhibit it. So if I'm experiencing negative emotions, if there's neurotransmitters being released during depression that are causing like this depression cycle to go on, if I block that with an electrical stimulation, if I inhibit those neurons from firing, well, now all of a sudden all the negative hormones aren't there, negative neurotransmitters, aren't there, which then leads to more positive mood, attitude, and behavior. Our last big topic within this field is psychosurgery. Psychosurgery is a technique in which we remove or destroy part of the brain. Formerly, this was known as a lobotomy, um, in which we would remove certain nerves from the frontal lobe through going through either the eye or the nasal cavity and basically cutting those parts of the brain off from the rest of it. The person would still have the ability to eat, sleep, breathe, interact, answer questions, but the thing that makes them them, that forebrain, that prefrontal cortex, is basically severed off from the rest of the brain and unable to communicate with it. Now, uh, we have done fewer and fewer and fewer of these. However, we will still resort on occasion to something called psychosurgery, in which we will perform not a lobotomy, a lesion, in which maybe we will remove smaller parts on a much more micro scale, in extreme cases as a last result. Every other technique that we've used up in here starts with the least impact to the individual's life. Psychotherapy is an hour a week. Psychopharmacology is take a pill. Even in the case of ECT or RTMS or deep brain stimulation, these are all treatments that you can start, and more importantly, they're treatments that you can stop. They're reversible, although ECT, the brain damage or the memory damage, not so much, and we don't know the long terms of it. So ECT is pretty close to a last step. But this is absolutely, because there is no going back and repairing the brain. Once we remove part of the brain, that's done. Oh, there's our handy dandy little picture of what it looks like to perform a lobotomy. So those are all kind of more progressively aggressive for dealing with psychological disorders. There's something that's much simpler. The textbook refers to as therapeutic lifestyle change. How, by taking care of themselves with a healthy lifestyle, might people find some relief from depression? How does this reflect our being biopsychosocial systems? Well, that's the big picture of it. By things like aerobic exercise, good sleep, light exposure, social engagement, negative thought reduction, nutrition, we can solve a lot of psychological disorders ourselves. Maybe not solve, but we can treat with good decisions, with good self-care. Inevitably, stress is both a cause and effect of our psychological issues. Good heart health means good brain health. Good sleep means, more positive interactions. If we look at this from the biopsychosocial, stress affects the brain chemistry, body chemistry, and health. I don't feel like myself. My brain starts producing more negative neurotransmitters. I don't take care of myself. Those chemical imbalances will then produce depression. Now I feel like I can't go out. I don't want to interact with people, which now makes me feel worse about myself. It's that reciprocal determinism coming back again. So the best way to do that is let's break the cycle at any one point. If the brain chemistry is the problem, we can change the brain chemistry with psychopharmacology. If the negative thinking is the problem, well, then we use cognitive therapy to change it. If the behavior is the problem, the not going out, well, then we can go ahead and we can use behavioral therapy, rewarding people for making healthy lifestyle choices. And I've referred to the meme where it's like so many former students I see on Facebook end up getting heated that, the boomer generation says to Gen X or millennials, like, oh, we'll just go for a walk. You do feel better after you go for a run. You do feel better when you have opportunities to go out and find opportunities to do life-affirming things, hanging out with friends. Obviously, we're shut in. We're stuck in the house for however long, so there are less of those opportunities. But doing things that you enjoy doing can help break that cycle, that relationship between the mind and the body. The last thing that I wanted to mention to you is the crash course. There are actually, by my count, is that 8 or 9? There are 9 different crash courses for this unit, which makes sense. 9 different modules, if I'm not mistaken. Disorders, OCD, anxiety, depressive bipolar, trauma, addiction. That trauma and addiction one is Maybe we don't need the whole one. I'm not sure. It's been a while since I've watched them. Schizophrenia, eating disorder, personality disorders, getting help, and biomedical treatments. So you'll see like the first 7 there are mostly about disorders, and the last 2 are only about like unit 13. So I'm going to call it quits there. We're just at over 20 minutes. So I appreciate you guys hanging tight. I am going to be available tomorrow around 1:30. Let me actually pull up my remind right now so I can give you exactly what I said in the reminds, which of course I have shut down because I am an incredibly smart person. Okay. So, yes, daycare is canceled. I'm home with the kids. Module 73 notes are coming up here shortly. That's what I'm doing right now. I'm going to be sharing crash courses from this unit. So tomorrow's live stream will be on Zoom. I'm going to aim for around 1:30, but since the kids are home, I'm going to appreciate your guys' flexibility on that. Once I'm done with the live stream, I will immediately throw up the 72-73 quiz, and I'm going to give you till the end of the day tomorrow to complete it. If you have any questions on coronavirus, if you have any questions on how we're handling teaching and learning, if you have any questions on the content, please make sure that you are available for the live stream tomorrow. Thank you much, guys. Talk to you later.